We now move to our third thematic block, Health Inequalities and Vulnerable Populations. This session will explore how cardiovascular strategies can better address inequities related to socioeconomic status, sex and gender, diversity, access to care, and vulnerable populations. We will begin with a short introductory presentation by co-fund Cure Heart and Brain Fellows Giovanni Maroli and Nely Rodríguez.
Cardiovascular disease affects every community across Europe. However, not everyone experiences the same risk, diagnosis, or access to care. Cardiovascular death rates are nearly 6.3 times higher in some member states than in others. Behind the same disease, there are very different realities: sex, aging, frailty, structural and socioeconomic conditions shape cardiovascular outcome across Europe and must be taken into account to reduce cardiovascular inequalities. Women often present different symptoms than men. Yet, medical models still rely on male-centered evidences, leading to delayed diagnosis, treatments, and worse outcomes for the female population. Women also remain underrepresented in research, clinical trials, and digital data sets. In order to close this gender data gap, we need policies that promote gender-informed diagnostic protocols, sex-disaggregated data collection, healthcare professional training, and equitable access to screening and care. Europe's population is aging rapidly. Cardiovascular disease increasingly coexists with frailty, cognitive decline, and multiple chronic conditions such as diabetes, hypertension, and arthritis. These scenarios require complex solutions. Policy action must promote integrated, holistic care, moving away from single disease medical models towards personalized management of multimorbid patients. Also, cardiovascular risk is heavily shaped by structural determinants like migration and housing, and invisible barriers such as discrimination and language isolation. These factors restrict healthcare access, accelerate cardiovascular aging, and worsen clinical outcomes for the most vulnerable populations. European strategies must integrate structural solutions, funding community care, and removing administrative barriers to reduce cardiovascular disparities and ensure basic health access for the entire population.
The socioeconomic status shapes cardiovascular risk in Europe and all across the world. Health inequalities are not only linked to income or social class, but to a broader spectrum of factors such as education, health literacy, access to healthcare, and last but not least, the opportunity. Because the clinical care explains only part of the cardiovascular outcomes, we refer to the social determinants of health. This can influence prevention and risk exposure and include education, economic stability, quality of healthcare, and other environmental and social factors. People with lower education have higher exposure to cardiovascular risk, delayed diagnosis, and worse outcomes, which is an example of a behavioral mechanism linking CES and CVD. Health literacy can be reinforced at multiple levels via interventions on schools, communities, and legislation. Here we see other examples of these behaviors linking CES and CVD. The good news is that many of them can be effectively modified. However, lifestyle patterns are strongly influenced by socioeconomic condition, and this starts early during life. And exposure to poor socioeconomic conditions over the course of a lifetime is linked to chronic negative psychological stress, which contributes directly to cardiovascular disease and cardiovascular aging through neurohormonal and inflammatory pathways. Environmental factors grouped in exposomes, which include exposure to pollution diet, pathogens, and more in general social conditions are important determinants of health inequalities and contribute extensively to chronic inflammation, cardiovascular aging, and immune activation. And recent studies show that inflammatory factors associate more clearly with aging and cardiovascular disease in industrialized countries, pointing to a strong link between the environment and biology in shaping health inequality. The inflammation is not universal, it depends on the environment. So the Safe Heart Plan represents an important opportunity to rethink cardiovascular health in Europe according to 4 principles: prevention, equity, data usage and integration, and inclusive policy making. The final goal should be to reduce inequalities and increase health literacy. And this is really needed because, unfortunately, health inequities persist even within well-organized healthcare systems as we have in Europe. To reach maximal access, availability needs to be coupled to other components such as affordability and accessibility. Indicators of social inequities and indicators of health inequities are essential to guide policy decisions that are based on evidence, and this has now been actively pursued by many countries in Europe. Observational studies can help us in studying better the interactions between CES and CVD. Other types of intervention focus on communities, and this can be tremendously effective, especially when targeting vulnerable population, such as children, migrants, and people who were incarcerated. Moreover, interventions on healthcare environments should focus on increasing health literacy at the patient care level. In conclusion, reducing inequalities is not different from cardiovascular prevention, and we think that equity itself should be at the center of cardiovascular policies in Europe. Thank you.
Thank you very much, Giovanni and Nely. Now I'd like to invite the moderator and panelists for this session to the stage. Moderating the discussion is Co-Fund Cure Heart and Brain Fellow Lucy Bulgakov.
So, hello everyone, welcome to this panel, Health Inequality and Vulnerable Population. The discussion will focus on one of the main challenges that cardiovascular health is facing today, and this is to ensure that the innovation, prevention and implementation strategies reduce the inequalities rather than reinforce them. It's my pleasure to welcome our 5 panelists. Sonya Babu-Narayan, who is Clinical Director at the British Heart Foundation, Reader in Adult Congenital Heart Disease at the Imperial College London, and Cardiologist at the Royal Brompton Hospital. So Juan Carlos Julián Mauro, who is General Director of the ALCER, which is the National Federation of Kidney Patients of Spain. María Rubini, Cardiologist and Senior Researcher in Ischemic Heart Disease and Sex and Gender Study in the National Center of Cardiovascular Research, CNIC. She's also chair of the Gender Task Force of the European Society of Cardiology and board member of the ESC. Rikke Vibeke Nielsen, who is health diplomat at the Royal Danish Embassy in London. And finally, Natalia Skogberg, Chief Researcher in Health Inequality and Diversity at the Finnish Institute for Health and Welfare, THL. So, thank you for all this applause. And so throughout the session, we will explore how gender, social determinants, migration, aging, and inequity continue to shape cardiovascular outcome across Europe, and how the implementation of this Safe Heart Plan can address these challenges. So we will begin with the first question for all panelists. The observation is that despite the major scientific and clinical advances, cardiovascular inequalities continue to persist across Europe. So in your view, what are currently the most important drivers of inequities in cardiovascular health outcome? I think you can start.
So I think the major driver of cardiovascular inequalities is deprivation. And many of the other factors that you beautifully presented already, intersect with that wealth and therefore health gap. So people living in the poorest areas are more vulnerable to air pollution, more vulnerable to poorer access to healthcare, more likely to have experienced lack of education or parents who are uneducated and therefore health illiteracy. They're more likely to, there are more migrant and minority ethnicity background for the country populations who also experience poverty. And for them, the way that we talk about health or try to empower and support may not resonate. For example, if we talk about a Mediterranean diet, what does that mean if that's not something that you're familiar with or the way that you eat food at home? How do we, there's more smoking and lack of smoking cessation services in deprived areas, worse housing, occupational risks and more stress. And meanwhile, people from the wealthiest areas have better outcomes. And there's many examples of this across member states, in the EU, and even within countries. So in the UK, if you live in Blackpool, you're twice as likely to die prematurely of cardiovascular disease below the age of 75 than if you live in Surrey, which is close to where I live. And meanwhile, why is this relevant to us as cardiovascular scientists, healthcare practitioners, and others? Well, it's relevant because it kills. The life expectancy gap we see between the wealthy and the poor is driven by cardiovascular disease risk factors, so obesity, smoking, hypertension, bad lipids. And it's not only driving a difference in lifespan, that can be a 20-year life expectancy difference in my borough between the rich and the poor, but it also drives a health span difference. So not only do you die younger if you're from a relatively deprived area, you will live with ill health for longer, and including ill health at a working age. So I would say that there isn't only a moral imperative, which we should all feel, there is an economic imperative, because if we cannot get our population healthier, we are losing people to the workforce. So the third most common cause of absenteeism in the workforce in the UK is cardiovascular, after mental health and after musculoskeletal abnormalities. So I think addressing this has both a health and an economic imperative.
Well, thank you. Dr. Julián Mauro?
As Sonya has said, there are many factors that are influencing this in this way. From the patient perspective, from entities like that works with people affected for this kind of issues, the approach is something different. Probably the question has seen that probably the health system and research have focused more in the disease than rather than the person living with the disease. This is a very important approach in order to analyze what are the factors affecting, in this case, the heart problems. But I'm sure during the discussion we can analyze deeply this kind of factor, but it's a multifactorial problem.
I completely agree with you. I think it's really a multifactorial problem. Maybe I would like to highlight three drivers that I think are important and are inequality in access to healthcare of those minorities. And I'd say it like this because if we talk, for example, of sex and gender, they are not a minority, are 50% of the population. Then inequality in awareness, and I think this is key for me. We need to raise awareness, and maybe we can highlight it afterwards how we can do this. And finally, inequality in terms of research. For example, if we talk from the gender perspective, we have underrepresentation of female in clinical trials and a lack of several factors that need to be improved, I think. So I will focus on those three drivers.
Thank you. Rikke, Vibeke, Nielsen?
Yeah, so thank you for the invitation for this fantastic event. I think also the socio-economic disadvantage is really a highlight, and it goes very along with what my colleague said. Lots of risk factors cluster around this disadvantage. along with the fact that it is a very strong factor when it comes to participating in prevention and early detection. So it really has that double burden. And when you get established disease, then it is enhanced even further. So I think this is something that you really need to think into the design of an early detection or screening program. So not just a cofactor, but really at the core of the design. Otherwise, you will not get the results that you want. And interestingly, the World Economic Forum, they published a white paper on early detection of non-communicable diseases earlier this year. It's very interesting to read, maybe for all of you. But what they concluded was that there's a larger variation in participation in screening programs within a country than across European countries. So that means that it is the societal factors in one single country that are very, very strong when it comes to cardiovascular disease. And that goes for all European countries. So you really have to look at that societal structure when you want people to engage in prevention and early detection of cardiovascular disease and all non-communicable diseases.
Thank you. Natalia Skogberg?
Yeah, thank you. Well, I guess the biggest, broadest answer that I can give is that we're trying to constantly come up with a one-size-fits-all solution. And when we're doing that, we are catering to maybe the majority population and the population who is already doing quite well. So when we're trying to do this one-size-fits-all solution, we are creating invisible barriers for different population groups that are already at a social disadvantage. And when we're talking about cardiovascular health, when we're talking about health overall, we really have to consider also the bigger picture. This is something that has come up in a number of talks already here today. So we really need to be addressing the structural drivers of health inequities. If we're focusing on individual risk factors, if we're only trying to find this one-size-fits-all solution, we're not going to get anywhere. Our population is becoming increasingly diverse, and this diversity is not just sex, gender, it's not just migration, it's disabilities, it's different socioeconomic circumstances, and we also have to be really mindful that it's not just women, migrants, persons with disabilities. There can be intersections of these. All of us have different social dimensions within us that intersect, and they can lead to different kinds of disadvantages. And one thing that we have encountered, for example, in the Joint Action for Cardiovascular Diseases and Diabetes, when we started, and we have this cross-cutting theme of embedding equity and diversity throughout the huge consortium of 143 pilot projects from 18 different countries, was that, well, it's a good idea, it's important to embed equity and diversity, but how do we actually do it in practice? So in Jakarta, we have come up with a conceptual framework on what are the key pathways that need to be addressed. And at the core of this is critical reflection. And the three pathways where critical reflection should be applied is context and data, co-design, and communication.
Okay, thank you, all of you. So we can see that there are many sources of inequality and its high challenges. So now I will ask some specific questions to all of you. So Dr. Babu-Narayan, what role should research institution, clinical organization and research funder play in addressing the socio-economic, social and commercial determinants that drive the cardiovascular inequalities?
Thank you. I mean, I think a brief comment about clinical organizations, which in a way is easier. I think it's quite important that whatever our clinical health and care structures are in our countries, that we have community and primary level live dashboards that tell us what's going on where, who is affected by cardiometabolic risk, including renal risk, and so on, so that we have an idea of prevalence in different populations, treatment prescription in different populations, so that where we so that we can balance lifting everybody with also targeting services to where they may be particularly needed and not being received or being underserved. In terms of research institutions and research funders, in some ways, I think it's not only a research problem, but what can we do? Well, we can test these cardiovascular prevention strategies in real-world populations. So, for example, the British Heart Foundation, where I work, we are in partnership with our government national funder, the NIHR, for a 50 million cardiovascular disease inequalities grand challenge at the moment, which is live. And this seeks to test different implementation strategies to better diagnose high blood pressure or abnormal lipid profiles, and also see to better optimally treat those factors, because it's not only that there are undetected populations, there are also people who never get a new prescription or an up titration. And this is targeted particularly to what in the UK is called Core 20+5. So that is the most deprived postcodes, so regions in the country, plus other underrepresented and in classic research and underserved populations, including people with minority ethnicity, for example, but prisoners, all of the sorts of groups, learning difficulties, people with mental health issues, and so on. So actually having some evidence behind the policies that we might in future implement. But I don't think it's about research alone. We do need to have an adequately resourced research and clinical workforce in order to crack these things. And we do need the intervention of government, which if there's a moment I'll come back to later. What else can you and we do as research institutions and research funders? Well, I think we can think and talk about research inclusion in the design of the research we do, everybody's research, not just people who are specialists in a labelled way on inequalities, so that and also how we have an inclusive and more representative researcher workforce. So, for example, in my research funding institution, we no longer will fund you to only study male mice unless there's a very strong scientific justification. If you're going to work with biobanks or other tissue, we're going to be asking you to articulate how does that tissue represent the disease burden in the population who would benefit if the results were successful. When it comes to trials, we all know, it's already been mentioned, that women are less likely to be invited, they're less likely to participate, and across nearly every single type of cardiovascular disease, women are underrepresented when it comes to participation to prevalence ratio. So now we ask you, when you apply for a trial, you've already done the patient involvement, you've already thought about how you're going to seek and get participation from traditionally underserved groups. And we're going to evaluate that when our reviewers look at it, they score on that, and we ask for your recruitment by sex disaggregation in your progress reports for the trial. We haven't yet said we'd stop funding the trial when you reach 50% men, but maybe one day. That's a provocative thought. But also I think it matters. Should it matter 40 trialists for a multi-center study are all men? I think it does matter. There's really good data that if you have a diverse workforce in business, in finance, let alone in research, you will have better innovation, better research outcomes, in turn, better patient outcomes and better healthcare, in turn, a fitter, more well population. So again, really important that we also consider how we recruit from the widest pool of talent, women, men, people from different backgrounds, so that every kind of perspective is brought into the mix, and including the fullest breadth of science diversity, behavioral science, social science, not only biological sciences. I think I better stop.
Thank you. It was a very complete answer. So, Dr. Julián Mauro, how can the patient perspective, psychosocial determinant, and patient and public involvement be better integrated in our cardiovascular research and healthcare strategies?
Well, I think it's a very important question, because I'm really happy because I heard before in the roundtables, in the previous roundtables, the importance of this kind of problems in this specific topic, in health issues. And even in if you have the best treatment as possible, the best treatment as possible may fail if you don't know how the people coping the stress, for instance, manage their fears, or navigate the socioeconomic burdens, for instance. And this is really important from the beginning, from the design. My recommendation for the young scientists is to collect data from the beginning, from the design of the clinical trials about the patient perspective. Last Tuesday, the 9th of June, has finished a specific EpiPermed, personalized medicine, focused on cardiorenal metabolic problems. In this specific call, it's mandatory the involvement of patient organizations as a partner of the consortium. And this is really important in this specific matter. Involve patient organization to collect data, to learn about the patient perspective, and include this data in your research.
Yeah, thank you. Of course, I think it's an aspect that is always, often missing. So, Dr. Skogberg, Dr. Rubini, please, have in another order. Why is it important that the Safe Hearts explicitly recognize sex and gender inequality in cardiovascular health, and what action are still needed to close these gaps?
Yeah, so we've heard that cardiovascular disease is the #1 killer for women in Europe. It's killing more than all cancers together. And still, women are underdiagnosed, undertreated, understudied. So therefore, I think it's essential that the Safe Hearts Plan has linked gender to prevention, diagnosis, and treatment. It highlights also female-specific cardiovascular risk factors. And I think very important is as well that it's promoting or is trying to close the gender and sex gap regarding research in its innovation and research roadmap that they have. And not just the Safe Hearts Plan, also the gender equality strategy from the European Commission. They are promoting gender-sensitive training, research, diagnosis, and treatment. And they also require a revision of the regulations, for example, the clinical trials regulation that is planned for the upcoming month. So I think it's very important that they are addressing this topic. We need to ensure that it remains not just a plan, but it's translated into an action. I think the implementation is here essential. And if you will ask me which actions I would encourage, the main thing I could mention is to raise awareness again. So in all the links of the chain, start with boys and girls at school. If you were born in a pregnancy with some cardiovascular events, you need to know you have a higher cardiovascular risk. The general population, how many women in their 50s, they will never miss a mammography appointment, but they don't know their cholesterol level. So, and medical students, they need to ask for gender-sensitive training. Of course, cardiovascular professionals and general healthcare professionals, ED, GPs, cardiologists, of course, and by last but not least, healthcare professionals, policymakers. They are probably one of the most important links of the chain. We need them for regulation, for funding, etc. So they are essential. And besides raising awareness, again, research. So we need more research and better research in gender inequalities in cardiovascular health. We need more funding. Therefore, we need not just politicians, but also the companies to invest more in those studies. Studies on female-specific risk factors or conditions. We need better regulations to have disaggregated data and to publish disaggregated data, not just to assess it, but also to publish. And yeah, that will be essentially where I will recommend awareness and better research.
Okay, thank you. It's right. I think that at the level of the, research using mice, for example, it's using different sex is something that is easy to implement.
Yeah.
More than social.
Yeah, I think
of course.
There are several aspects. For example, the revision of the clinical trials regulation is going to be essential because there we can discuss what can we aim. For example, with ischemic heart disease, it's when I say, okay, they are underrepresented in clinical trials, female, they are saying, okay, because it's less frequent among females. So still we could try to aim to have 50-50, even if we know it's underrepresented. So it's one of the strategies that we can discuss. And of course, another huge topic I had the opportunity to discuss 2 weeks ago with the European Medicament Agency. How can we improve the clinical trials in pregnant and breastfeeding females? And this is a huge topic as well that needs to be addressed.
Okay, thank you. So, Dr. Nielsen, why does tackling cardiovascular inequality require a system-wide change from the basic science and clinical trial design to the prevention policy and societal action?
So I think throughout the day it's been really beautifully presented how it's a very interconnected disease group with both systemic, societal, biological factors. Which is also why there needs to be a change in the systemic thinking in places like ESC, but also in the funding bodies where I used to work, at the Novo Nordisk Foundation, the British Heart Foundation, places like that. They need to, maybe sometimes it doesn't have to be a requirement per se, but at least it has to motivate and nudge people in the right direction and enforce them to be mindful about equity. So I know that Maria and I have discussed this previously on women's health, that I think everybody here knows that the research is very cumbersome, both in terms of conducting it, finding funding and publishing it. So maybe sometimes we have to be mindful not to introduce too many requirements. But it's a difficult discussion because sometimes requirements really fast forward things. But at least the alternative needs to be that you demand that people have thought about it when they design their studies, so they can answer to why the distribution of sex, for example, is not equal, and there needs to be a good reason for it. So that is why it is such an interconnected disease group. But then on the positive note of that is that when you have a very interconnected disease group, you also have a lot of modifiable risk factors. So I think that for cardiovascular disease, there's so many common risk factors, and even if you extend that to cardiometabolic disease, and I know that at CNIC they have also shown the connection to some cancers, you have the majority of non-communicable diseases, and you have a potential to design prevention and early detection that actually talk to the majority of that disease group. So I think there's a lot of potential. It's a very still an area that is very under-delivered, despite there's a lot of strong research, especially for the cardiovascular part. Cancer is still further ahead when it comes to screening, but I think there's a huge potential for this disease group.
Thank you. Thank you. So, to finish, Dr. Skogberg, how well does the Safe Heart Plan currently incorporate equity and diversity perspectives? And what should member states prioritize when developing national cardiovascular strategies?
Yeah, thank you for this very broad question. So first, a mini analysis of the Safe Hearts Plan from the perspective of equity. In the Safe Hearts Plan, equity is one of the 3 cross-cutting themes, and the other 2 themes are very much connected to equity, of course, which are digital solutions and research and knowledge. So from the perspective of digital solutions, how they link to equity, it has been mentioned in the discussions today as well. So when we're creating digital solutions, that's the way we're going forward. It's the future. But at the same time, digital solutions require digital literacy. And when we are heavily relying on digital solutions and really too fast moving forwards towards these, we might forget the populations who may not be able to access these digital solutions equitably. And these are not just older people, but it can also be, for example, migrants as well, or other ethnic minorities, like in Europe, for example, we have the Roma population. In terms of AI, well, there's a lot of opportunities in AI, but of course a lot of biases can be created since we are relying on existing data. And then if we have gaps in data in terms of equity, if we're missing data on, for example, some population groups, they are invisible in the data. And so then AI will then reinforce these biases in the innovative solutions. In the Safe Hearts plan also, there's a lot of emphasis on research and knowledge, and that's really important, of course, so identification, filling up the data gaps. Participation is also something that's very well incorporated or very well mentioned in the Safe Hearts plan, and it's approached, for example, through inclusion of persons with lived experiences, engagement of patient representatives, and also multi-sectoral collaboration, so different stakeholders. That's something that's really important. There's a lot of mention of personalized solutions, so it sounds like there's a wish towards moving from this one-size-fits-all approach to this personalized way of going about things. But of course, when we're talking about personalized things at population level, it's not as easy to create personalized solutions as compared to when we are working one-on-one in clinical practice, for example, where we can better take into account the personalized solutions. So in terms of when we are working at the population level, so for example, working at the population level on prevention and screening, then we really need to segment the population that we are dealing with. And the Safe Hearts plan mentions, doesn't actually maybe mention so much segmentation specifically, but there is a clear mention of populations in vulnerable situations. And by populations in vulnerable situations in the Safe Heart plan, there are several groups that are explicitly mentioned, and these are women, duly, which is really important, of course. So sex, gender perspective is well taken into consideration. Other groups that are mentioned are persons with disabilities, persons with low socioeconomic position, then regional differences are also mentioned, and youth. But the thing is that in the Safe Hearts plan, the way the populations in vulnerable situations are actually addressed, it's maybe not so systematic. So kind of at different points of the Safe Heart plan, there may be variations in which groups are mentioned. So maybe still more systematic approach when we're doing the practical implementation would be needed. And one group that I was actually missing in the Safe Heart plan, an explicit mention of migrants and ethnic minorities. And in a Pecha Kucha presentation that was mentioned, that was just before our panel, it was clearly mentioned, and we have research evidence that, yes, persons of migrant origin, they are, or ethnic minorities, they can be overrepresented in lower socioeconomic groups, but at the same time, it's not just a determinant that's just because of the socioeconomic position, but we also have evidence for independent contribution of migrant origin or ethnicity to cardiovascular health. So we really need to take that also into account. And then kind of on a more practical level, how to translate this into practice. So when we are compiling national plans, so we really need to be aware of who all are in the population that we're dealing with. So segmenting the population, identifying who are the main groups in the population, main subgroups, and then identifying kind of what can be done, what do we need to do, engaging these groups. So that it's not just us professionals who are creating the solutions, but then we're really engaging the populations who we want to be working with. And then the last thing that I really want to also mention is monitoring and accountability. So it's not just enough to have like a conceptual framework, for example, as we have in Jakarta. We also need tools, and in Jakarta we have created practical tools on how we can go about embedding equity and how we can actually monitor these perspectives. So maybe the member states who are working with the national Safe Hearts plans, they could take some lessons from our experiences as well.
Okay, thank you. So to conclude, we will go for one final short question, but some of you have already started to answer it, so maybe it will be faster. So if you could introduce one concrete measure tomorrow to make cardiovascular health in Europe more equitable, what would it be and why?
I think I would aim for every single household to have a blood pressure machine, because the biggest thing, the quickest thing that would change health is if we adequately detected everyone who had hypertension. And as a clinician and a scientist, I need to pick something that would be doable and deliverable. And that, I believe, is deliverable at that scale. It's £10, I don't know, $12 to have an NHS grade blood pressure machine. It should be available to everybody.
Okay, thank you. Dr. Julián Mauro?
Well, this is really difficult for us because we are not physicians, but probably the future will change. For instance, in artificial intelligence, is really important to analyze what data are missing. Of course, gender discrimination is clear, but also data from the patient perspective is missing. In this moment, we have the vision, only the vision of the professional, the researchers, and something like that. And probably the future to reduce these inequalities needs a multidisciplinary approach. Little by little, in more European calls and in more projects at European and international level, it's more important to organize a multidisciplinary panel of professionals working in the same line. And in this specific topic, in heart issues, it's especially important a broad vision about not only clinical vision, the vision of other professionals that can help in reduce this kind of problems.
Okay, thank you for making this clear. Dr. Rubini?
Yes, so I think it is essential that we make sure that we move from the plan to the action, so that we don't remain in this plan, that we move into implementation. And for this, I think the younger generations are essential. So I like not to advise you, but to ask you that for help, that you require gender-sensitive training. For example, when we talk about gender inequalities, for example, from the ESC, we made a revision about the curricula, so we ensure this, that you always call for disaggregated data, even if it's sometimes difficult to publish, not just in the supplement. And finally, that if you are passionate about doing research in one of those vulnerable groups, that you push for it, that you don't give up, because it's sometimes more difficult, but it's worth it and it's necessary.
Thank you.
Yeah, I think I'll try to keep it short, but I can see the clock is blinking very red. But I think it really is that awareness cross-cutting through the systems that we have talked about today, so that it is a call for action, as you say, Maria, that we all go home and ensure that everything from basic science to policymakers and funding bodies ensure that equity is thought into the plans, and that you demand answers for it in whatever work you do.
Thank you.
I would say strengthening competences among health professionals would be central, and strengthening competences in critical reflection and also competences in conceptual frameworks on how to take into account the equity and diversity perspectives, as well as practical tools on how to actually apply the theory into practice.
Okay, so thank you to all of you for this very rich session, and we will leave the stage for next panel. Thank you.